Okay, everybody, we're up and running here, so I don't want to keep you too long. So, yeah, I wanted to thanks for the invite. I wanted to talk about gestational diabetes and oral hypoglycemics, kind of an interesting topic over the years, and share with you some data. So, I wanted to just start with talking about diabetes just for a little bit in general, because it may inform our discussion later. I think it's good that we talk across specialties too. You know, Steve Jobs was famous for that. That part of his philosophy was that he would design the building so that people of different disciplines, like an engineer and a artist, or a cartoon, software developer, could be forced to talk to each other. So oftentimes we just go in our own little directions. We don't interact with each other. So I think it's good that we get out of our specialty a little bit. But so this is I think you guys probably know this is how we diagnose diabetes these days. The hemoglobin A1C has been now is an accepted way to diagnose type 2 diabetes, basically, or any diabetes. And you can also do it with fasting sugar, 2-hour postprandial glucose of 200, random postprandial glucose as well, in people with symptoms of hyperglycemia. And the A1C is a 3-month average integrated blood sugar, and this is how it correlates basically. Of course, you guys need tight control in the setting of gestational diabetes, especially the postprandial sugars. And to get that tight control, to get that tight control at the lower A1Cs, you need to hit the postprandial sugars, definitely. And now in diabetes in general in the world, adults with diabetes, over the long run, many years, you can show a decrease in microvascular complications. Now, macrovascular, much to the dismay of some endocrinologists, there was a big trial called the Accord study that was halted early. So in terms of these patients in that study, they were at high risk for heart attack and stroke. They had 10 years of diabetes, and they tried to really control the A1C down to 6, let's say. And they failed to show a benefit in terms of heart attack and stroke. And actually, the trial was stopped early because there was increased mortality in that study in the intensively treated arm. It's a very difficult study to interpret, but suffice to say that if you had a short duration of diabetes, very tight control, if you're newly diagnosed, it seems to be very important. And there is data to suggest that that will prevent heart disease down the road. But if you wait 10 years and then try to very intensify treatment on these patients, they don't do well. Kind of logical when you think about it, but needed a NIH randomized study to show that. So that's right. Parachutes. You need one for parachutes too, right? So here we just see the goals for adults with diabetes. Of course, we shoot for stricter goals in gestational, and you individualize the targets based on all these comorbid conditions that may be there, in particular cardiovascular disease and duration of diabetes as well. And age, I would say, because if somebody's 80, we don't want to really put them on therapy that could hurt them with hypoglycemia, etc. So in this pre-diabetic setting over here, the A1C of 5.7 to 6.4, I mean, there's half the world is in that range these days, and the recommendations are weight loss, and even to consider metformin in those patients who have a BMI of greater than 35, and women with prior gestational diabetes actually is the recommendation there. And the reason for that, metformin can sort of delay progression to diabetes, can quote-unquote prevent diabetes, can encourage weight loss. So we love it. It may even prevent cancers. I mean, that's a completely unproven thing at this point, but there is a lot of interest in the cancer setting with metformin too. oral agent, third oral agent, and you could add a basal insulin to orals, or you could just say, forget the orals, they're not working, let's go with 4-shot insulin regimen. There's a lot of options out there now. We'll just take a quick look here. You know, the main thing I want to draw your attention to, which is relevant to us in this discussion, is the hypoglycemia and weight gain issues, right? Because glyburide is notorious for causing hypoglycemia. We really don't like to use it much anymore. It has some other issues potentially with ischemic preconditioning in the heart as well for long-term use. But metformin, of course, is weight neutral and, or causes weight loss modestly. Now, this information has gotten out there, so my nurses are all bothering me to prescribe them metformin now, right? Because anything that is going to give them a little weight loss, who wouldn't want that, right? So we have other drugs that are more potent at weight loss, like Byetta, Victoza, Bydureon, these GLP-1 agonists, which are injectable as well. But that's basically how it divides out.
How do you deal with the diarrhea?
Yeah, it's a good question. I think you start slow and try to titrate it up. I mean, most people get used to it. Well, not chronic diarrhea. The side effect sort of goes away with time. The body adjusts to it, I would say. And you know, I mean, most type 2 diabetics are on 2,000 milligrams a day, 1,000 morning. Another tip on that is, yes, extended release metformin maybe is better tolerated. And of course, you know, here we see the A1C lowering. Of course, you know, insulin sort of has unlimited A1C lowering. The other drugs, you know, have variable, but metformin and sulfonylureas are potent drugs, oral drugs. Now, this is regarding testing patients for diabetes in asymptomatic adults. So if the BMI is greater than 25, you begin testing no later than age 45. Okay. This is a lot of people. That's you know, I think a reasonable thing to do. And let's say you get a pre-diabetic range of 6. Are you?
We're doing early testing.
Yeah. Are you finding a lot of you know, positives there? Yeah.
A lot, but I think that we're picking up some that we wouldn't have picked up earlier.
Yeah.
If we waited to 28 weeks, then we
Yeah. No, I think that's a very good strategy. You know, I think that's a good strategy, really. I mean, you know, you could even, if you believe in using metformin or, you know, an oral, you could. We'll get into some data on that in women with PCOS. There was a trial that looked at that. You know, they weren't able to show that giving metformin to these women with PCOS in a randomized fashion prevented gestational diabetes, however. So I think it depends on the patient, on you know, how high the A1C is as well.
I think a lot of people stop doing that. Part of the issue comes when you have the patient, the PCOS patient.
Yeah.
That's at least I think for me what I've had the hardest time with in the past 6 months. You have these PCOS patients who are on metformin, whether or not they have a diagnosis of insulin resistance. If they have a diagnosis of insulin resistance, it's a little easier. But they're on metformin, even if they don't have that diagnosis, in the hopes of helping them ovulate and increase their chance of conceiving.
Yeah.
Now they conceive. Now they're 7 weeks. What are you doing with that metformin?
Yeah.
And there's the problem.
And there's a myriad of literature. Yes, you keep it. No, you don't.
And you know, and a lot of them are like, one patient I had, she's 400 pounds.
Yeah.
Wow.
So,
Well, she's probably, I mean, not all obese patients are insulin resistant, but you know, most of them.
Some of them are high risk. So you know, I probably should keep on that metformin, but I don't really have the diagnosis. I'll be keeping you on.
Yeah.
So.
Yeah, and the question is, you know, I mean, with metformin, we'll look at some of these studies here. Let me get to this. This is just talking about all the problems from diabetes that can occur. Cancer actually being one that I think is not emphasized enough.
So Dr. Baez had a question. You call your MFM and ask him, and with this patient, the patient did not want to come off the metformin.
Yeah.
So my colleague told her to come off it one day, went back on. I called the MFM. I said, what do I do with this patient? They said, take her off. Do an early glucola. And so that's what I'm waiting for, because I'm giving her a couple weeks before I get that glucola. But
did they say why are they not comfortable with it? Just
they said
because not
unless you
enough
have the
data?
diagnosis, don't treat it. So I'm not sure.
I thought most repro endo, if they were using it to get patients pregnant, they keep them on it until 12 weeks.
But this wasn't an infertility patient. She just managed to
Okay.
spontaneously.
What was her A1C though? Was her
Her
A1C?
A1C was normal. I want to say it was 5.1.
Oh, I see. Okay.
So her A1C was normal.
I might take her off. Yeah, I mean, you know.
I did have a normal.
Yeah. Yeah.
But you don't have an informal A1C on that form.
Well, that's a good point. Yeah, that's a very good point. Yeah.
This is what I've had the most confusion with lately, is the patient who really doesn't have a diabetic diagnosis, and what am I doing? If the metformin drops it by 1.5, then she's really sick.
Yeah, that's the max dose of metformin. Yeah, yeah. 1,000 BID under best case kind of scenario. It may drop it by 1, but right. No, that's true. That's true. So, you know, without it, it's going to go up, and it's probably going to bring out some amount of insulin
But
resistance.
you're going to test her again. I mean, the principle is, I mean, medicine, right? I mean, if you don't need to take medication and you document it, I mean, you should not be like, I don't want to take medication if I don't really need it. So
Absolutely.
if you do 1 hour early, which we tend to do a lot of that now, and then you repeat it at 24 to 28 weeks, you know, then, you know, we still have time to get her with.
Yeah, fair enough. Yeah, that you know, if you just keep an eye on it and take her off. Yeah, I think both are valid.
I'm looking at these things here, and I don't see the fasting glucose. Is that like testing number?
Well, for gestational, that's not really the way that's.
But I mean, prior to gestational, like a non-pregnant patient.
Oh yeah, so on one of the earlier slides, you know, to diagnose diabetes, yeah, 126, fasting glucose of 126. Pre-diabetes, triple digits, so 100 to 125 is considered impaired fasting glucose. Yeah, which, you know, it's not as sensitive as an oral glucose tolerance test to pick up type 2 diabetes, the fasting sugar. You know, but, yeah.
The most, I don't know, but we use 1 hour plus training less than 120. So it's pretty strict, but I just
Yeah. Yeah, I think right. You know, I mean, the ACOG versus the ADA, they have some difference there. Yeah, I think ACOG. I think they say less than 135 though. No, for the 1 hour.
Yeah,
Maybe
it's 128, 2 hours.
Okay, so you guys are. Yeah. Okay, so here we go. That's the same. The two options here. You know, what they're saying here is at the bottom, if you read the small print, threshold of 135 and high-risk ethnic minorities is recommended by ACOG.
It's 120.
Okay. Okay, but let's. So in general, ACOG has endorsed the use of orals, but not the ADA at this point, and they're not approved for gestational. So let's look at some of the data on this. You know what? Well, this is just an interesting little slide about perinatal mortality in type 1. Skip that. You know, the complications occur with the A1C, major malformations, I should say, occur when the A1C is about 8.5. All right, let's go to the data on the two drugs, the glyburide and the metformin. And I mean, this was a pooled analysis by Johns Hopkins that looked at a bunch of different randomized studies and observational studies. And the observational studies are hard to be definitive about, but they basically didn't find much difference here in terms of insulin or oral hypoglycemic drugs. There was no increase in adverse outcomes. The same first author, the same group, did a 2009 systemic review and systematic review, and looked at trials again, the same situation here. They also looked at one trial comparing insulin, glyburide, and a weak drug called acarbose. One trial compared insulin to metformin. And they didn't find any difference in maternal glycemic control or cesarean delivery rates. So we'll look here in more detail. This was a meta-analysis that they did of glyburide versus insulin. And, you know, anything to the right favors glyburide, anything to the left favors insulin. And the lines are all crossing the the confidence intervals are all crossing the midline. So that it essentially means there's no difference here in the birth weights. Now, the second point in there on this slide is regarding hypoglycemia. So in this study by Rowan in the New England Journal in 2008, there was less hypoglycemia with metformin than insulin, as we would expect, because metformin does not cause hypoglycemia. Now, this is again a 2010 paper that kind of tried to pool these randomized controlled studies, looking comparatively at insulin and oral agents. And again, their summary was that they didn't find any difference in outcomes. So we'll look at it in a little more detail here. These were the studies they looked at, and you can see, there was the total number of patients, not huge, but something at least. And the two of the trials involved metformin versus insulin, and then 4 involved glyburide. So the largest metformin study was the Australia study, and that was in that study. I think you guys may remember that about almost half the women on metformin eventually needed insulin, which is high. The other metformin study, they didn't in New Mexico. They didn't require insulin. And now in one glyburide study, the percentage of women requiring insulin was much less. One of these studies, it was 4%, but then the same group reported in their real-world clinical practice that it was actually 20%. Are you guys finding that a lot of people? Have you tried glyburide on anybody? Yeah. Do a lot of people then require insulin?
Most of the people, this is anecdotal, that I found that need insulin probably have some type of maybe pre-gestational diabetes.
Yeah.
They're requiring
just
insulin on top.
Yeah, so they had a more severe situation to start with.
They didn't know.
Yeah. Yeah, right. Oh, that's common, yeah, I tell you. Now, in this same study, they looked at postprandial control, because one of the knocks on the oral drugs, the metformin and the glyburide, is that they couldn't control the postprandials as well as insulin. But in this analysis, there was no difference in the postprandial control across these studies, which is very important, right? Because that's what you guys target, to lower your complications. So I think that's now glyburide in general. The negatives. I kind of think of it as an old yesterday's big thing, because nowadays, we have so many other better options that don't cause weight gain and hypoglycemia and have this baggage about this ischemic preconditioning. So that's just how we think of it in type 2 diabetes, and it's unfortunate, but it's the well-studied oral medication for gestational. Just to put that out there for you. The 5th International Workshop on this topic advised caution on use of it, but it is the most commonly used drug, and I think it's definitely effective. Now, the transplacental passage of the drug, I think there's conflicting data. We'll take a quick look at that too. There's no increased risk of neonatal hypoglycemia or congenital anomalies that was found. The adverse effects on the offspring have not been demonstrated either at this point, although long-term studies may be needed for that. So I think in general, if you're going to use it, you just have to tell the patient, look, there's some uncertainties, but it appears, as far as we know, it's safe at this point.
Is there any studies that we've probably been using it maybe about 10 years now?
Yeah.
So, anything going forward that say, teenagers are getting complications from moms using
not that I know of. I think that would be nice to in some of these randomized studies to report a long-term follow-up. I haven't seen much data on that though. I haven't seen any data on that. You would think they could do that though. As long as the patients weren't lost. But this was one such study, in the New England Journal from 2000. You folks probably remember this. They had mild gestational diabetes, mean glucose was 105 in both groups during treatment, and so they gave either glyburide or insulin. So there was no difference in these outcomes: macrosomia, hypoglycemia, neonatal hypoglycemia, etc., or in cord serum insulin concentrations. Because since glyburide, it stimulates the pancreas, it really squeezes the pancreas, so that is a concern. Now, 4% in that study required insulin, and as we said before, then in a subsequent report, 20% required insulin. I have this quote there by Lois Jovanovic that, this was regarding a metformin study, but I just threw that out there to, I mean, how do you guys feel about that? I think, in some cases, as long as you are monitoring and you see what's happening and the glyburide isn't working, I kind of feel you can shift it to insulin without harming the baby. So, but she's a big insulin person.
They don't have any studies on anti-insulin antibodies, because sometimes you have patients who are in excellent control and you still have a macrosome.
Huh.
And are people looking at that?
Well, were those patients obese though? Because I think, to my knowledge, more patients with just plain obesity have macrosomia. You know what I mean? The obesity itself drives macrosomia so much. That might be the reason. But I don't know of any studies like that. Yeah. Yeah, you should.
That's right. That's right.
Neonatal adiposity is another concern. Okay, so this was a study of about 100 women randomized to insulin and glyburide, and there was no significant differences in the neonatal fat mass, BMI, etc. Now, more infants were greater than 4,000 grams in the glyburide group than the insulin group, but they were underpowered to detect small differences in outcome in general in the study. So.
Is that 22 and 2.4?
Yeah.
I don't care how much small difference. It's a lot.
Yeah, there's a difference there, right? I mean, it's small. It's 41 patients, so that's different. Yeah. And now, in terms of the transplacental passage, there was this study looking at this in vitro. So it looks like it can be transported against a concentration gradient from the fetus to the maternal circulation. And and in two other studies, the cord levels averaged 70% and 77% of maternal levels. Caveat being the levels were low, the absolute levels were low at the time of measurement.
So, since it stimulates the pancreas to make insulin and it passes the placenta, the baby's pancreas then kicks in and makes a lot of insulin and gives these babies a big bottom up.
No.
Yeah,
there may be, but
in the randomized studies there was not, but in this retrospective studies set me up for this one, there was. So I mean, I think the best quality studies are the randomized studies, right? Because when you do a retrospective analysis, you never know what's confounded and everything. But in this retrospective study, they did find more NICU admits in the glyburide group versus the insulin group, primarily due to neonatal hypoglycemia. I mean, you know what though? But I mean, this is an outlier. I'll say that because all the other stuff we looked at, all the other randomized studies, which are better quality, did not find. But yeah, they could. So it's some caveats that in obese patients it may be less successful, or obviously if the patient's got terrible glycemic control and oral is not going to cut it, and you need large doses of insulin. There's some questions about whether if you treat with the glyburide in postpartum progression of women to frank diabetes, would that be altered, and would it alter the risk of recurrence and the long-term well-being of the offspring, like somebody mentioned? Those studies, I just haven't seen anything like that. So those are some questions out there. I mean, in my opinion, if you treat with glyburide for a pregnancy duration, I don't think it's going to necessarily, make you at higher risk of developing diabetes. I think the bottom line is follow-up after the pregnancy in lifestyle, in
we
weight loss.
Know that for of our gestational diabetes that has become diabetics as they age.
Yeah, good
So
point.
we're watching that.
You're watching
Like
it.
G1
Yeah,
men.
it's extremely high risk.
Right.
Yeah, good point.
So, I don't know if it has anything to do with the price of gold, but it's
Yeah.
just their
Yeah,
metabolism. That's the nature of the beast.
that's true. Yeah. No, you're right. So let's talk about metformin quickly here. So metformin, in type 2 diabetes, it's the first-line drug. It reduces glucose output by the liver, and it increases energy expenditure in skeletal muscle. So that's probably why it causes a little weight loss. It does have the GI side effects, and like I said, it's the hot drug in seeing if there can be some synergy with active cancer therapy or even cancer prevention. Now, second and third trimester metformin treatment appears to be safe, but a lot of women need insulin to achieve glycemic targets in comparison to glyburide, so 25 to 50% of women. So let's look. This was the Australian study, the biggest study. 751 women with gestational randomized to metformin or insulin, and they reported perinatal morbidity as a composite rate of those, what you see there, neonatal hypoglycemia, respiratory distress, blah, blah, blah. 1/3 of the women in each group experienced this endpoint, so it was even. It was no different. There was no difference. But again, a lot of these women needed insulin to, rescue, basically. Almost 1/2 in that study actually needed it in the Australian study. So.
We really don't know what happens to the baby. Only 50% of those patients were determined.
Yeah, because I think you can.
They just took them off the metformin and put them on the insulin.
Yes, that's right. Honestly, but since you brought that up, I mean, I use that all the time in type 2 diabetes to add a basal insulin to orals, and it works pretty well. It may not give you the tight control that you need in pregnancy, though. For the postprandial specifically, but we that's a successful regimen. Either sulfonylurea, glyburide plus Lantus insulin, or metformin plus Lantus. Oftentimes it cuts just to. I don't think that's been studied in gestational really, but I think that should be. So let's do the study. So glyburide has been directly compared to metformin, and the glyburide did result in a higher rate of good glycemic control. You can see in this study that only 16% of the glyburide group needed insulin, but 35% of the metformin group needed insulin. This is a head-to-head study. So, no.
So glyburide is a sulfonylurea, right?
Yes.
There's a sulfonylurea.
Yeah.
So we wouldn't use it in the third trimester anyway because of the glucose phosphate dehydrogenase problem we have with sulfonylurea stuff in pregnancy. We're worried about the baby having the. But it doesn't matter. The Mediterranean people, Greek people, anybody in the Middle East, they have that deficiency. So we tend to stay away from sulfur drugs in the third trimester.
That's interesting. Yeah. In general though,
I think if that's going to be the case, people look for it prior to starting their month. Most of them, you're going to launch the medication to control their blood sugar all the way through.
Well, that's the point. That's why I was
by analogy to type 2 diabetes, I mean, we don't worry about,
You're not worried about baby.
That's true. So you're worried that the
The sulfonylurea, because you need glucose 6-phosphate dehydrogenase to metabolize it. So you wouldn't use that, so you wouldn't use even metformin. I stopped using after the third trimester because of the sulfonylurea in it.
well, metformin is not considered a sulfur drug.
No, but it has a cross-reactivity for allergies. So.
I don't know. I mean.
Not metformin. I'm sorry, not metformin.
Yeah.
Metformin.
I see. Yeah. Yeah. There is some kind of weak cross-reactivity with sulfonylureas. I mean, I can tell you though, in these studies,
Crossing over with the glyburide, right? So you're more concerned about the fetus or with the mom? But there's so little that they say crossing over.
So then what do you do with the patients on glyburide in the third trimester?
I don't put them on. I put them on insulin. I don't.
Yeah, I mean,
that's
it's,
my point. They don't use it.
but you're specifically concerned about certain ethnic populations that have the.
Right. They kind of spoke.
Right. So that's the concern, is that they have this
Right, they have
the G6PD thing.
Yeah, these fathers may end up.
Yeah, you know, I honestly I haven't encountered that specific problem though. The G6PD with sulfonylureas, you know, it's not a. Wouldn't that be also a problem in type 2 diabetes though? You would figure that giving that to, you know, that population.
Well, usually by the time they're type 2 diabetics and they're adults, they've already just figured out that they have the enzyme.
Okay. Okay. All right. Well, let's hit this last point about metformin. You know, whether it could. There's a theory that if you give it to people with gestational diabetes, it could prevent it. But you know, in observational studies, that was suggested, but in randomized, it was not proven. So this was the study of 273 pregnancies. They gave them metformin or not, and there was no difference in the prevalence of gestational diabetes in this group. So this was kind of getting at the point we were mentioning earlier. But I think it depends. You know, I didn't the starting A1C and all that. It depends on the population. I mean, obviously, it's going to lower the blood sugar, and it is going to, you know, ameliorate that whole situation. So I'm a little surprised. I'd have to look at the study in more detail. Now, metformin does cross the placenta, and it's unknown whether that exposure for a fetus is good or bad. But there was this metformin and gestational diabetes study, the MIG trial, and they did a 2-year follow-up. Okay, so there was no difference in central adiposity, but there was an increase in sub-Q fat deposition. You know, as we know, you know, sub-Q, it's better to be an apple than a pear, right? If you got a big butt and big thighs, it's better probably. The visceral fat is the dangerous fat. And in this, so again, you know, that increase in sub-Q fat, you know, we don't know. You know, the point is that until the age of 5 to 7 years, you know, you can see if the child is more obese as a result of this. I find it hard to believe, but we don't know. You know, so we need that 5 to 7 year data. I think. You know, there's some uncertainties about this transplacental passage. Okay. Last drug is acarbose. There was one trial comparing it to metformin and glyburide, and this is used in Germany, but it causes gas. Because it works in the intestines to block the absorption of dietary carbohydrates, so it slows the absorption of carbohydrates, and as a side effect, you get a lot. So the Germans love it for, you know, they don't mind the gas. And so this is really this. This is unstudied. You know, it's basically very unstudied. It can cause abdominal cramp. It's not well tolerated. It's not well used and much used in type 2 diabetes. So this is the summary here. It's difficult to draw conclusions. I mean, we can each take away from this what we want and how we interpret this. I wanted to leave you with this point that you know, that is something I think which is could be promising. If you just add a basal insulin to orals, it's much easier for the patient than making them.
How much pump?
Pump. I mean, so you know, I use some. I think it's being used more and more because. Yeah. Do you? Yeah. Yes, please. Yeah.
So I had a patient. Apparently, I've said this to patients. I had a patient who came in recently. She's on Pcos.
Yeah.
And metformin.
Yep.
She will not come off because she is a bus driver and she will not be able to work.
Wow.
If she goes on insulin. Within 3 months of going on insulin, you are not allowed to drive and you're responsible for school children according to New York State.
Wow.
Law. So I think we've gotten around it in respect to the fact that she recently had her physical exam with the Department of Transportation. So if I switch over to insulin in the summer, they won't know.
Yeah.
But so I switched over to glutaride. It probably won't hold her. Would you put her back on metformin with the insulin, keep her on glycerol with the insulin. I mean, I need to put her on an insulin. And Dr. Heller wants her off the Victoza. You know, she said, take her off that Victoza, but she wouldn't stop it until after that appointment.
You use both of them, the glycerol and metformin together?
Yeah, in type 2 diabetics. I mean, in pregnancy, you know, now you're getting into really,
Polypharmacy.
yeah, you know, because there's some questions about, you know, little questions about each. So, but yeah, I mean, they synergize, and they will both lower the blood sugar synergistically. But to get that patient, yeah, that's tough. The Victoza is a great drug. It causes weight loss. It cuts down on eating. So if you switch it increases insulin secretion and lowers glucagon, but it slows gastric emptying and it creates satiety. So it's very interesting. You know, it causes weight loss really, and it's just exactly what we want. There's always, you know, there's some questions about it too. You know, safety concerns, the long term, but that patient, I mean, you could give them metformin plus. You could try metformin plus the
When you put her, because metformin is what she's on.
Yeah.
It was Dr. Heller's recommendation, RN, to take her off the Victoza and the metformin and put her on glycerol, because we knew metformin was going to hold her, doesn't hold her not pregnant.
Yeah.
You know, so.
So she's going to gain a lot of weight off the Victoza and on the glycerol. That's the problem. Which, you know, the macrosomia issue. I wonder if she'd be better off on metformin plus basal insulin, because you know, you titrate the basal up to the fasting sugar, and making sure that they're not, you know, getting lows overnight.
So she's coming in today or tomorrow.
Yeah, that's how you use the basal. Yep, exactly.
Physical exam with last Friday. She is probably now about
13.
So she's been on the Victoza this whole
you know,
time.
Look, another option with that patient is one shot of rapid-acting insulin when she comes home for dinner. Then she's not driving anymore. And usually people pig out at dinner, right? Because we're all busy during the day. You don't eat anything all day, and then you come home and you reward yourself and you go crazy, and you keep going back to the fridge. So that would be a good regimen too.
You gave her the long-acting before dinner.
Well, no. So the long-acting, whenever you want, in the morning, at night, but the rapid-acting with dinner. And continue the metformin, because see, the metformin will help with the breakfast and lunch sugar.
Okay.
You know, too. So yeah. So
So apparently I didn't know any of these rules, but you know, I've had a number of people confirm that she'd be pulled out of the bus.
if she just started insulin.
She just started insulin.
Right, because
She's
they
good.
hear hypoglycemia.
Yeah.
Yeah. I mean,
for a mother, I understand it, but yeah.
yeah.
Something happened in your life.
She's in the song.
Yeah.
Yeah.
Thank you.
My pleasure. Thanks.
Yes. Yeah.